I'm hoping will be something that will be of benefit to many of you in terms of being able to have access for health services research. So the objective of today is just to describe this mechanism and the rationale behind it, and to answer any questions that you might have. So the first thing is, why do we need a new data release mechanism in Ontario? Well, Ontario has lots of great data for research. I've listed here data sets located at ICES, the Institute for Clinical Evaluative Sciences, as well as Cancer Care Ontario. And what you see is that the first three lines there, Ontario Cancer Registry, some vital statistics, and the cervical and breast screening data sets, are currently the only data sets that are shared between these the two organizations. ICES, in addition to the cancer data that it gets from Cancer Care Ontario, has lots of other data related to the healthcare system within Ontario, so OHIP claims, Ontario Drug Benefit, CIHI, etc., and is able to link all of this up for health services research. So ICES is the place where most of the analyses that require linked data sets have occurred. The problem is that it hasn't been quite as easy to access data at ICES as one would like. I moved up to Toronto or Ontario from Boston about a year and a half ago, and when I was looking over documents related to my new position, I came across this one, which were minutes from a meeting about fostering collaborative health services research in Ontario back in 2005. Where the passage and the underlining came from the minutes, I didn't add this here, is that a marked improvement in access to data housed at ICES by those working outside of Toronto is needed to advance the field. Several participants noted that this constraint in access to data has been a long-standing issue. And certainly ICES has recognized this, and that's why there's starting to be satellite ICES sites, first at Queen's, now at Ottawa, and there are others in the works. But in truth, I had been aware of this before because I tell the story that one of the fellows that I had down in Boston was a young researcher from Ontario who had a period of fellowship time to do a research project, but when looking at the time it would take to get a project through ICES and actually done, and as well as the funds needed to do it, it was actually more feasible for him to move to Boston for part of the year, and we've now published 3 or 4 studies on the American healthcare system, health services issues there. And in fact, this is someone who, since I've moved back here, I was unable to recruit back to Ontario. He stayed in Boston and did an MPH, et cetera, at Harvard. So this is a tragic loss, that the barriers that exist for doing research have actually led people either not to pursue this form of research or to pursue it elsewhere. So when I came up here and saw this issue, it prompted me to try to find a way to correct it. So the goals of the CDLink program are to make standing linkages of existing data sources available really as an infrastructure research for cancer health services researchers, and then to put de-identified linked data directly into the hands of those researchers. So the program is modeled on the SEER Medicare program that exists in the United States and has existed since 1993. And for those of you who aren't familiar with it, SEER is a group of very high-quality tumor registries in the United States that now cover about a quarter of the population. And in the SEER Medicare program, patients in those registries are linked to Medicare claims, death index, census data. You can request hospital files that give information about the providers, and there's a variety of other data sets that it's possible to link to with that. And these are de-identified and at a relatively low cost sent to investigators anywhere, both within the country and without. So there are probably people on the phone who have analyzed these data for various uses. And these are individual patient level data, and that's something that always causes a lot of concern about privacy. How can you do something like this? Well, I think as has been articulated by our host, Dr. Khaled El-Imam, rather than taking a very conservative approach and saying it's too risky to send out to link data and to give researchers access to individual patient level data, that we really need to take a more nuanced view of this and try to balance the very real issues of personal privacy protection versus the public good that can come from making data about a public healthcare system more available for research, analysis, increasing transparency, etc. It's really balancing four issues. So first of all, what is, in a particular data set, what is the actual probability of re-identification? If you've stripped various things and et cetera, there's always a finite risk that a particular patient could be identified. That's been shown, but there are various risks depending what's been done to the data set. And given that it's impossible to ever get the risk down to zero, what other mitigating controls can be put in place? So for example, with the SEER Medicare program, in order to obtain the data, you have to sign a data use agreement that describes how you're going to keep the data safe, what you can and cannot do with the data, particularly around trying to re-identify or link up to other things. The third issue is, what is the motive and capacity of anyone to re-identify someone in a data set? So different data sets have different levels of sensitivity, and is there really a motive on any third party to identify, say, someone who has had kidney cancer? And even if they do have that motive, well, it might be technically possible to re-identify a particular patient within a data set. It can be actually very, very difficult and costly if you were to set about to do that. And there are examples, for example, of the New York Times spending $100,000 to try to prove that they could identify one person within data that I believe Yahoo had made public. And so looking at that and saying, do people really have a motive and capacity to do this? And then lastly is, what is the extent of potential privacy invasion? So some cancer data sets, there are clearly sensitivities around it. How does it relate to other things such as around HIV status or employment or various things? So is there really the same extent of privacy invasion in the data sets that one is looking at? And so the idea is to take a look at every potential data release and try to balance these things before making decisions about whether and how data can be shared. So for the CDLink program, as it's currently constituted, this is a list of the data sets that are available. They're the data sets that are currently shared between Cancer Care Ontario and ISIS, as well as several of the routinely used ISIS data sets. So the Discharge Abstract Database, Ambulatory Care Reporting System, Home Care, Drug Benefit Claims, OHIP claims, the two screening databases, and then most important from CCO, the Ontario Cancer Registry, and then also the Registered Persons Database. So how does the program work? What are the procedures? Well, the first thing is you have an idea for an analysis or a research study. And then it involves writing up a proposal. This isn't meant to be an onerous thing. We're looking for something like a 5-page proposal that just outlines the rationale and objectives of the analysis that you'd be wanting to do. the data sets and variables that are required and why they're required for the analysis, what the planned analyses are, what the expected products of the analysis are. So is the idea to create a scientific research study or something that's targeted for the front page of the Toronto Star, for example? What are the data custodian resources? And by that, I mean, where will you be able to keep the data set? In a password-protected computer, in a locked office, in a key card-controlled building, this sort of thing, as opposed to, it'll be in a laptop in a backpack, and that's all that's available. What the timeline for the analysis is, so that we can set up a data use agreement that has an end date. And then listing the research staff, anyone who's going to be touching the data, we want to know who those people are. The next step is a review of that proposal. And in setting this up, it's being run out of ICIS, and we've been trying to preserve as many of the procedures that ICIS usually uses for research studies as possible. So the review occurs through the ICIS oncology program, which meets monthly and reviews all new proposals that are going through ICIS. The focus of these reviews are privacy primarily and feasibility. So if your proposal says we're trying to identify your Aunt Bitsy who had kidney cancer in Aurora, well, that's not a good thing. So just to make sure there isn't any obvious privacy issue. And then secondly is feasibility, and this comes from discussions with people who've run the SEER Medicare program, that they'll get proposals that say we're going to analyze patterns of lung cancer care based on whether people are smokers or not. Well, with the data sets that are available, that's just not feasible, and so we wouldn't let a proposal like that go through. And the third thing is just novelty in the sense of if you put in a proposal and someone else has just put in essentially the same proposal a month ago, we'll let you know. Now, it doesn't mean that you're not able to get the data and, may the fastest and best researchers win, but we'll try to let you know if there's obvious duplication coming so that you don't spend a lot of time and effort on something that you're likely to be scooped for. But it's not a review to approve methods or to prioritize analyses in any way. So for that, we're really relying on peer review, on the complexity of the data. These just aren't things that you can put a CD in your computer and put it immediately into the software program and start running things. And then also the transparency. There have been several examples within SEER Medicare where the fact that any other researcher is able to get essentially the same data set and reproduce your analyses has been a useful thing and has moved the methods of the field forward. Often the reproduction is someone who has an idea for some incremental analysis, and in the course of it, they end up replicating something and finding, either confirming or finding differences, and then a discussion can occur about why that is, whether it's selection of the cohort, etc. So because the ICIS Cancer Program meets on a monthly basis, this review should occur within a maximum of 4 weeks of submission of any proposal. Once approved, the next step is to sign a data use agreement and an ICIS confidentiality agreement. These are just standard things that happen at ICIS. The data use agreement, I won't go through this in excruciating detail, but you can read through here that it's essentially a contract with the investigator saying that you're only going to use the data for what you said you would use it for in the proposal. You're not going to try to identify specific people. You're not going to try to recontact people. You're not going to pass these data on to other people, investigators. You're not going to try to link it up with other data sets. The issue of research ethics approval is just to say that it's the responsibility of the investigator to seek whatever research ethics approval is appropriate. And given that most journals now require some sort of a statement about research ethics approval, that's something that we would presume you would get at your own institution. It's not something that at this point we're planning to police in any way. And some of the other things, cell size suppression. So any cell size in a table that contains fewer than 5 observations has to just be listed as less than 5. That type of thing. Pre-publication review, etc. I'll mention again in a minute. So then the next step is a data request form, and we've drafted a data request form, and we'll continue to revise it to try to make the process as streamlined and simple as possible. But basically what it involves is defining the cohort of patients that you're interested in and which data sets and variables you're interested in. And this is something that there can be communication with the ISIS analyst and program to clarify and finalize. Once that's done, then we cut the data sets. And now I'll start telling you what we do to the data sets to de-identify them. So when I say data sets, they're all linked by a common and project-specific identifier for each patient. So for example, if your project requires the cancer registry, OHIP claims, and drug benefit claims, you'll receive 3 different files, but every patient in those files has a unique scrambled identifier that can allow you to link them all up. So the first step in de-identification, we wanted to make these data sets compliant with HIPAA, which is the American privacy legislation. And the reason for that is that HIPAA is both more prescriptive than the Canadian legislation is, and also felt to be more restrictive and conservative, and so we wanted to have a high bar for this. HIPAA in the legislation says that there are really 2 ways that you can de-identify data. One is to remove the 18 restricted variables that are listed here, and the second is to do statistical operations to minimize the likelihood of anyone being able to re-identify particular individuals within the data sets, and we've really done both. So as we look at these 18 restricted variables, the first 5 are the main ones that would be pertinent to any of the data sets that we're discussing here. And I'll show you what this means. So if you see in the first line, there's a analytic data set that contains the actual personal health information. It's got the patient's name, OHIP number, etc. And so the first step in what we do is we obviously remove name. We scramble the OHIP number, the health insurance claim number. And one of the innovations of our procedures are how we handle dates. So according to HIPAA, any date more specific than a year is considered to be personal health information. So what we're able to provide is the year of birth instead of the date of birth, and the year of a cancer diagnosis, given that here we're looking at cancer patients for this. The Ontario Cancer Registry actually provides a specific date of diagnosis, however, and so what we're able to do is provide those 2 years, but then every other date, in every other data set is replaced with the number of days relative to, for now we're using the date of diagnosis, but of course it can be anchored to anything. So if you've got a situation where you're not actually using the cancer registry, it could also be linked to date of birth. So in this example, you would know that this patient was born in 1946, was diagnosed with non-Hodgkin's lymphoma in 2007. 117 days later was admitted to hospital, maybe day minus 520, had a heart attack, something like that, was treated by a physician whose identity is scrambled. and then died 184 days after diagnosis. And so for most research uses, this is actually enough information. There are situations, I always trot out an example of a paper I wrote a few years ago looking at influenza vaccination in cancer patients and its effect on treatment tolerance and outcomes. And there you did need to know that certain things were happening in October through December. But for many uses, knowing the number of days between certain events can still be quite useful. And then able to supply ecological, socio-demographic type of information like median income in a region, but either increasing the region or applying a fuzz factor, for example, rounding certain variables so that they're still useful, but when combined over a large data set, satisfy this requirement of not being too specific. In the United States, in the HIPAA legislation, the cutoff is any geographic area less than 20,000 people, which falls around the county level. Some counties are less, some are more than 20,000 people. So that's the first step of what we do. And then the second step is the statistical anonymization. And for that, we use the Privacy Analytics Risk Assessment tool, which Dr. Earle has developed. And the idea here is, to boil it down, it's essentially to make sure that there are not too small a number of people with any constellation of demographic characteristics that would allow re-identification. So for example, this first prosecutor or nosy neighbor risk, the idea is if you knew that your next door neighbor had been diagnosed with kidney cancer last year, well, you know this person, you know an age, you know a location, you know a diagnosis, etc. If you were to get a hold of the data set, could you find your neighbor? Well, you probably could. But if you're able to make it so that the characteristics of that person are shared by at least 3 or optimally 5 people, well, then that adds a degree of uncertainty, which really it brings it up to, I guess, industry standards at this point. So if, for example, age, if you knew that he was 72, but the age is banded 70 to 75, and there are at least 5 people living in your area diagnosed with kidney cancer last year in that age group, well, all of a sudden, you can't really pull your neighbor out that carefully or that exactly. The marketer risk is similar. It's could you link up another data set, essentially. And so we take the data sets that we create and we actually run them through this software, which gives us estimates of the risk of re-identification based on the data in the specific data set that we're thinking of releasing to you. So for example, here we're looking at sex, birth year, FSA is the postal code region, etc. And then what the software does is assists us and suggests ways that we can bring it down to an acceptable risk. So I've just told you banding the age or the year of birth into 5-year groupings might be something that could do it. And this is something that we work with the investigator to decide what are the most acceptable ways of doing this for your specific research project. So it could be that we need to enlarge the geographic region to the LIN instead of a smaller FSA area, and maybe for your analysis that's fine. Or you may make a decision that, you know what, if there's 0.1% of patients for whom we have to suppress the sex, that maybe that's a more acceptable way for the analysis that you're doing. But this is something that we can go back and forth until we find a way to bring it down to an acceptable risk, but still something that's going to be very useful for your analysis. And so in doing this, I think we've really created a new type of data. if we think of different levels of data sensitivity, there's identifiable record level data, which is what is housed at ICIS, and even people here at ICIS, there's only a handful who can actually access that sort of data. Then there's de-identified record level data, which would be like the HIPAA data, and then aggregated data like you publish in a paper, etc. And we've created something that we're calling risk-reduced de-identified data, or R2D2, because it really is somewhere in between. It goes beyond the de-identified record level data in terms of its safety, but yet it's more useful than aggregate data. Our goal in doing this was to have data sets that even if the worst thing happens, that the investigator breaks the data use agreement and leaves the CD in the back of their car and their car gets stolen, etc., that this is no longer personal health information, that it's not really a problem because it would be so difficult to re-identify any person within this data set that an event like that, although we never want it to happen, would not be expected to have ramifications. So, this being Canada, trying to set wait time targets for everything that we do. So if we can approve a project within 4 weeks of receiving the application, I'd like to get it so that within 6 weeks of having signed a data use agreement and completed the data request form, that we've been able to go through this process of cutting the data, of de-identifying it, and sending it to you. So currently, the way we're doing this is on encrypted disks sent by courier. Eventually, it's probably even more secure to set up a way that you can download it directly. And so we'll be able to do that. The third bullet here is eventually we'll also incorporate a cost recovery element to this. So currently, and for the next foreseeable future, I'm supplying this through funds through my program as a something to help kickstart this program and help researchers throughout the province. Eventually, we will want to build in some sort of cost recovery for that, but the goal is not to have cost be a barrier. I would like to keep it so that any sort of data request could be accommodated for under $1,000, hopefully a few $100s, something like that, and not for that to be a significant barrier to doing research. But currently, it's free, so sign up now. So after the analysis, we do require, and it's outlined in the data use agreement, that any manuscript before publication has to be sent in to us for review, and that's really for two things. The first is to make sure that that there are no privacy breaches, and this definitely does happen inadvertently, where there's a table that has 4 people in it or something like that, and so it's to pick up on that before the paper is actually published. And then the second thing is the data sets that we're using that exist at ICIS already have a requirement. So ICIS has a requirement that any research that's going to be published using these data sets have to be sent with I believe it's a 30-day notice to the Ministry of Health and to Cancer Care Ontario. Now, this is not so that the Ministry of Health can come back and say, oh, this is embarrassing, you can't publish this. This is for there to be a heads up that there's going to be this publication coming out, and if it's going to be on the front page of the Toronto Star or whatever, they want to have a heads up and not be blindsided by it. This is a long-standing thing that goes back almost 20 years, and because that's where these data come from, the requirement still holds here. But this won't hold things up if you recognize that there's going to be, say, a 45-day that this has to be sent in 45 days before any publication comes out so that we can have these 30-day reviews and hear back. If you don't hear back, everything is fine. The other thing that happens after the analysis is that the data use agreement specifies that the data have to be destroyed. So the disks that we send you have to be destroyed, the data sets have to be deleted, and there's actually a form that we send you where someone from your institution testifies that these data sets have been destroyed. Now, if in the course of what you're doing you realize there are further analyses, another study that requires the same data, then that just requires submitting a new proposal, and if that's approved, then it's a new data use agreement. You don't have to get the data cut again, or you don't have to buy it again if we're into the cost recovery phase. And similarly, if things are taking longer than was initially anticipated, you can get extensions on the data use agreement. But we just need to know about it, and we just need to manage this and to have a view of where our data are. Have they been destroyed after after the data use agreement is up? And this can also, the data use agreement can specify that you're not just keeping it and destroying it after the analysis is done. You can specify that we're going to keep it for a certain number of years afterwards for inquiries, et cetera, that we get. But there does have to be a date at which the data goes away. So we had our first release of a data set on March 25th. So we're now in this new era of cancer health services research in Ontario. We have a second request that's come in since that's currently in process. There are some initial restrictions. Initially, the Cancer Care Ontario data, so that's primarily the cancer registry, come with the stipulation that they're only available to investigators at academic institutions within Ontario. Now, I'm expecting this to expand in the future. We heard very clearly when we had meetings with the IPC, the Information and Privacy Commissioner's Office, as well as Ministry of Health, that this is not a necessary restriction. And because of that, if there's a project that does not involve the Cancer Care Ontario data, this does not apply to the data that are just coming from ISIS. And in particular, that would mean that if there's an investigator outside of Ontario who is interested in obtaining those data, that is a possibility right now. It was a concern of one of the Cancer Care Ontario lawyers, though, about passing data across provincial lines. I think the level of de-identification, the fact that these are now, according to many definitions, no longer personal health information, gets around a lot of that. But for now, that's what's in our collaboration agreement with Cancer Care Ontario. So to conclude the presentation, I'll just say that I think we need to recognize that privacy and research are both public goods. It's not just all about privacy, that research has benefit. And with proper safeguards in place, both of these can be optimized. The Ontario Information and Privacy Commissioner, Dr. Anne Kavokian, has described a positive win-win paradigm of trying to protect privacy, but then also allow information and data to be used. And that's the philosophy we've been trying to follow in this. So in terms of where we're going with this, there is a web page now. If you go to the ISIS website, in the header there's a link called About Us, and if you click on that on the sidebar, CDLink is one of the things that are there. And at this point, it's just a description of the program and the data sets that are available. But as time goes on, especially if there's demand, we'll find ways of increasing the amount of information on there. Data dictionaries, SAS code procedures for various things, etc. And we could also consider having data users workshops once people, more people start getting experience and using these data. We also hope to expand so that we can include other data sources. As you recall from one of my first slides, there are a lot of other very important data sets at Cancer Care Ontario that currently are not routinely shared with ICIS: radiation data, new drug funding data, et cetera. And so we're working on an initiative right now to broaden the data sharing agreement between these two organizations so that there's a two-way data sharing. And what that would mean is that if once those data sets become part of the routine library at ICIS, they can be incorporated in this program as well. And eventually would like to be able to link up to data in other provinces, other countries, to, again, improve the usefulness of the resource. And I see this as a model for other diseases. Interestingly, I've been surprised actually since March 25th that a lot of the interest has come from investigators not specifically interested in cancer. And really the non-cancer data are a subset of the CDLink data. So we can certainly entertain, especially at this point, proposals that may not require the Cancer Care Ontario data and may not be focused on cancer, with the idea that this is still a new program for us. We're interested in trying to get experience going through these processes, and so with that rationale, I'm willing to also support non-cancer projects. In the long run, my funding and mandate is about cancer research, and so we'd have to find another mechanism for supporting non-cancer research through this. But I think the opportunity is great. Also, anything that we can do to improve the data quality. Many of you will know that a big problem with the Ontario Cancer Registry has been that we haven't had a lot of really good staging data, but that is improving enormously in these last year or two, and so going forward, this is going to be an even better resource than what we've had at ICIS in the past. And then another area of interest, both for Dr. Elamam and myself, is are there ways of allowing remote access so that you don't necessarily have to keep the data on your own computer, but it can be kept within the ICIS firewall, but yet you'll still be able to do the types of analyses that you need. And this may be a way of getting around some of the regulatory issues about sharing data across different provinces and different countries, because if there's a way of being able to safely analyze data without the data actually moving, then that's something that might end up being more feasible in the future. So with that, I'd just like to acknowledge some of the many people who have made this possible through different types of efforts, and to just give you my email address, because certainly if you're interested, have other questions that don't get addressed on this webinar, feel free to send me an email, and I'd be happy to discuss with you. So with that, I guess I'll minimize my screen and see if we have any questions here. So let's see, I've got, how will this work to improve registry data quality? Well, I'm not sure it directly improves registry data quality, but I would hope that if there's more being done with the registry, that there's more value being created from the registry, that's an impetus to for investments into improving the quality of the data, whether it's by Cancer Care Ontario, Canadian Partnership Against Cancer, et cetera, who, by the way, right now are putting a lot of resources into improving the registry. Next question is, are all the data linkages to create these files done through the lens of the RPDB, i.e. including, and I'm not sure I can read the rest of that here. Okay, maybe I can. including only records that have a valid OHIN. So it is true that the linkages only include records that have a valid OHIN number, so a valid health insurance claim number. That ends up being, it varies a little bit from year to year, but that ends up being approximately 98% of all records. And one of the things that we have as part of our standard operating procedures here is that when we create your data set, one of the things that will come with the data set is a printout that shows the number and percentage of observations that were not linked, as well as basic demographics about them. So the age and sex, etc., of the people who were not included as part of the linkage. It ends up being quite a small number of patients, and certainly if you look at any other data linkage resource, it's better than I think basically any of them. The next question I have here, and it seems maybe I'm going down in the wrong direction, will these slides be available afterwards? The answer is yes. The slides have been, Dr. Elamam has them, and I guess, Khaled, are you able to say right now where people would get access to the slides? Are you there? Are you muted? They are available on the website through this program. Charles asks, is there any specific arrangement for the CCO review? The CCO review, as I mentioned, the procedures have been designed to follow the ISIS procedures as much as possible. The cancer program at ISIS is headed up by Dr. David Urbach, and he functions as Cancer Care Ontario's representative at ISIS. So he chairs the monthly meetings that approve all projects, and he has to sign off on them as Cancer Care Ontario's representative, and recognizing and representing the interests of Cancer Care Ontario for that review. Now, if the question is more about the review of the manuscripts afterwards, how that is currently set up is that it goes through Mitch Toker's group. I guess it's communications, or I may be getting the name of the department wrong, as well as Carol Saka. So the current mechanism is that the manuscript is sent there with a summary, basically an abstract bottom line type thing, which preparation of that we can have assistance through the knowledge translation program of the OICR CCO Health Services Research Program run by Ava Grunfeld. So it's essentially sent there with an abstract, and if there are any concerns, of course, then they're able to get back to us. So let me see. Rural health researchers typically encounter small sample sizes in small populations, a level of detail that is essential to analysis. How will CDLink accommodate this need while maintaining privacy, etc.? So it'll depend on the specific type of question. If the issue is looking at what happens to patients in communities of a certain size, for example, well, those can be combined so that there's enough patients with specific demographic characteristics. If you get into a situation where it's necessary for your analysis to look at a specific geographic area that has a small population, and we're not able to satisfy the requirements of there being at least 3 people with a constellation of characteristics. And remember, there's a lot that we can do depending on how you need your analysis. We can band age into very wide groupings. We can suppress some other characteristics, etc. If it's just impossible, then that might be a situation where the this mechanism doesn't work. But I would have to say that I'm quite optimistic that we'll be able to find a satisfactory way for most analyses to address that problem. In most cases, you're looking at the characteristics of the population or of the geographic area, and those are things that can be grouped. Next question: do you know how up to date the Ontario Cancer Registry data is, date of death? I do know it, or we do know it. It is known. Whether I'll get the numbers right, sorry, off the top of my head is another question. If you're looking, so date of death is one thing, cause of death is another. Cause of death lags behind 2 or 3 years. So cause of death currently in the Ontario Cancer Registry is, I think, up to around the end of 2007. And date of death, so the fact of death, I believe is known currently up to the end of 2009. It's updated, I believe, roughly quarterly, so it's something that, a month later can be even more up to date. So the date of death for overall survival analyses is fairly up to date. The next question: while CCO data are currently limited to Ontario-based investigators, data available within ICIS are already available to investigators outside of the province. Is this correct? Yes. So even British Columbia is an option here. I think at this point it's still for investigators at academic institutions. In the long run, I personally don't see that that even that restriction necessarily has to stay on. Excuse me. Certainly, the SEER Medicare data are routinely used by contract research organizations and pharma and things like this. But there are obviously that is a different. There are sensitivities around that, and at least initially, it's not in the view of this. But down the road, that is a possibility. But yes, currently, if you don't require any of the CCO data, the other data are available. Pogo, if the data is non-human subject data, why do you need ethics review? Well, that's absolutely true, and that's why I've said we're not policing this. So the SEER Medicare program, the NIH does not consider it, well, so I'll say two things about that. The SEER Medicare data is not actually as de-identified as what we've done here. So SEER Medicare data is still what's called a limited data set, but is not de-identified according to HIPAA, right down to that level. Ours is. Even that being said, NIH does not require data. So if you're reviewing grants, if you put in a grant to NIH, it does not require that analyses that use SEER Medicare data have IRB, is what they're called in the U.S., IRB review and approval. So it's a very good point. That being said, I and I guess all investigators that I know still put their proposals through an IRB or an REB just because you don't want to be caught out, taking the high road for this. And also just the very practical issue that when you submit something for publication, you usually have to say something about this was approved by the local research ethics board. SEER Medicare projects in IRBs in the U.S. are generally given an expedited review, so it's a bit of a formality, but probably one that I would advise is worth undertaking. Where can we get a list of potentially available data sets and the specific data elements? So the data sets are on the slide that I had put up there. You can email me and I can send it to you again. It's also, they're listed on the website that you get through ICIS for CDLink, ISIS, click on About Us, click on CDLink on the sidebar. Currently, the data dictionaries, so the specific data elements, are not on the publicly available web, but are on the ISIS intranet. And there's some technical, we've been trying to see if we could get that put up on the outside part. Currently what happens is that once you put in a proposal, ISIS will give you access to its intranet, which gives you access to all the specific data elements. Now, obviously that's, we can probably, we're still in the infancy of this, we can probably get you access as you're developing your proposal, and that gives you access to those things. Otherwise, there are, we can give you, text versions, etc., if needed. Next question, are chemotherapy data, type of agent, date of administration also available? So yes, to a certain extent. What you'll have is the OHIP billings related to chemotherapy. So you'll know that chemotherapy administration was billed for on this particular type. And in OHIP, the specific drug is only billed for in certain situations. So high-dose cyclophosphamide, cisplatin. There's a number of drugs that are considered more complex that have their own billing codes, and so the actual agent can be determined from that. The New Drug Funding Program, which goes really covers any drug that was approved from Taxol onward in the early 1990s, has much more detailed information, but is not currently part of the ISIS Cancer Care Ontario data sharing agreement. And so if you really need to get into the specifics of new drugs, currently we're not able to do that through this mechanism. Hopefully in the near future we will be able to, but not right now. We are interested in early stage breast cancer chemotherapy. How far back does the staging data go, and what is the quality? The staging data is, I guess, for now, if you were putting something in now, it would be best to consider that you essentially don't have staging data. When we broaden the data sharing agreement, we will be able to, I'm expecting to be able to have staging data, but the quality is very poor once you get even 1 or 2 years back, meaning you may have 60% of cases within cancer centers only, which is about 60% of cancer care, so 60% of 60%. It ends up being not very good. That being said, people have found other ways of inferring whether someone had early stage breast cancer, and so there are analytical ways of trying to do that. It's not optimal, but stage is one of the weaknesses. Going forward, it's going to improve dramatically, but for now, stage is a problem, and we need to look at the specifics of what you need to know and what has been done previously to handle those issues at ISIS. If I wanted to get a linked data set of data and NACRs for chronic kidney disease, would this be possible? So at this point, yes. So of course it's going outside of the cancer part that we've envisioned for this, but as I say, we are interested in working out the processes and procedures for this, so so we should be able to do that. And let me see, we're getting towards the end, and I think I've answered all the questions that have come up. So I've got a clinic to go to shortly.